All right, three great talks. Now, it's time for question. So my question to Evan, so for patients who have metastatic prostate cancer who are on abiraterone and prednisone, like what is the role of prednisone? Like how much does it add to the responses?
Yeah, I'm not sure that prednisone adds anything to the response with abiraterone. The main reason we give prednisone there is just to prevent the mineralocorticoid excess. So if you look at the phase 1 data when they were developing abiraterone, they actually started off without any steroids. And what they found was that, they saw a lot of patients with mineralocorticoid excess, and they would add things like diuretics, hydrochlorothiazide. They would add things like mineralocorticoid antagonists, like eplerenone. That works as well. So if you have somebody you really want to avoid steroids in, you can. But what you really find is that once you add steroids back, and that's those initial studies, they use Decadron and prednisone. You can use either one. They found that actually when you add it back, that those side effects go away quite quickly. In my personal experience, I've had patients that were really resistant to the steroids or didn't personally resistant. They didn't want to take it. And what you find is that most of those patients develop pretty quick hypertension. And what I usually do, I have a few that I've managed just with diuretics and mineralocorticoid antagonists. But if you add back just a low dose, it usually takes care of it. So oftentimes when I'll just use 5 milligrams a day.
Sure. Yeah. Great, thank you. Now, you showed that abiraterone and enzalutamide, they cause a lot of cognitive side effects to almost 20% of the patients. Do you think we should do a baseline psychology eval, and should we hook them to psychologists? Because these patients may end up living for many, many years, and that is a huge, huge problem in terms of quality of life.
Yeah, I agree. I haven't done that, but what I do is I do a depression screening scale with them, and oftentimes I'll have them fill out some quality of life questionnaires. For instance, FACT-P is something that we use in prostate cancer to just kind of document what their baseline is, and then we'll follow that over time. But I'm very detailed in paying attention to those side effects. There are things that can be subtly missed if you don't ask the right questions. But what you do find is a lot of patients on enzalutamide, especially those more elderly patients, however you define that, those patients will report more memory loss. I can't ever remember where I put my keys, or just more subtle things like that. But so I do think it's worth documenting some sort of baseline. It wouldn't be wrong to send them off for an assessment.
Sure. If you have any questions, please come to the mic. While you're coming there, I have a question for Dr. Bhatia. So for pembrolizumab, as you showed, even after you stop pembrolizumab, most of the patients end up having stable disease, or they may stay in CR for quite some time. Do you have any suggestion about what should be the duration of treatment? Because what you stated is true for many other cancers where we use pembrolizumab. It is not only for melanoma.
Yep. Binay, that's a very important question, and I don't think we have a definite answer at this point, but I think that data suggests it's okay to stop therapy in people who are doing well. Now, in that trial, therapy was stopped at 2 years, but I think we are getting complete responses happening much sooner than that. And also, quality of life issues are becoming important because many patients, as you know, report fatigue, and that can be quite debilitating, especially when they're doing well, they're cancer-free. It becomes an important issue. And with all those things in mind, I think what we need to do is also answer the question of stopping therapy a bit more earlier in the course, and maybe coming up with strategies like maintenance therapy instead of continuing therapy every 2 weeks, every 3 weeks. Maybe doing maintenance doses every 2-3 months might be sufficient to find the right balance there.
Are you aware of any clinical trial that is looking at shorter duration of therapy,
Well-
either in melanoma or other cancers?
Yeah, so I think the field is slowly coming around to that. The trial that I presented, I guess, is a step in the right direction, supporting that it's okay to stop treatment. Many of the newer regimens are now, for example, maintenance portion of ipi-nivo combos is now using nivolumab every 4 weeks instead of every 2 weeks. So I think people are moving in that direction.
Sure, thank you. Dr. Samuels.
Another question for Dr. Bhatia. So
Yes.
given that the attraction for IPI is the sort of tail of 25% long-term survivors, and given the fact that we don't expect a rapid response with immunotherapy, but also given the excessive toxicity of the combo, have people looked at sequencing it, IPI first and then the PD-L1 inhibitor?
So IPI was the monotherapy that was first approved
Right.
for melanoma, and with the recent data showing that PD-1 monotherapy is better, so now most of the patients are getting PD-1 monotherapy as the frontline therapy. The question, I guess, what you're alluding to is, instead of doing IPI-nivo combo up front, could we do PD-1 monotherapy first, and then if the patients are not responding, maybe do the IPI-nivo combo or do IPI after that? Is that?
Well, no, I was saying that it seems as if the ipi-nivo combo may be superior to monotherapy. But the question is, would sequential rather than simultaneous give you a similar result with significantly less toxicity?
Well, yes, we do not know the answer to that, but I think that's probably what we should be thinking about. I mean, the data does not convincingly show that doing the combo upfront actually adds to a major survival benefit. So in the absence of that survival benefit, whether to do combo upfront or not really depends on patient preference. Some patients want to be most aggressive. They want that higher response rate and the potential chance of survival benefit, and they're willing to accept toxicities. And in that situation, I think doing combo upfront is reasonable. Others value quality of life more, and I think doing PD-1 monotherapy first and then reserving the combo for later on, or ideally get treatment in a clinical trial will probably be the most appropriate.
Kenneth Deaton, Macon, Georgia. For Dr. Gold, for a patient who stubbornly refuses radiation adjuvant therapy after surgical resection of head and neck therapy, is there any other adjuvant treatment you might consider?
So not one that there's any data behind. I have used chemotherapy alone, mainly in the situation where someone has had chemoradiation in the past, has a second primary tumor, gets that resected, and has high-risk features, but is not a candidate for further radiation therapy. And I have done a couple cycles of cisplatin-based, normally a cisplatin docetaxel, in hopes of reducing the risk. So I think that would be reasonable. That said, I mean, I don't think that a cisplatin-based chemotherapy doublets are all that much easier to tolerate than post-operative doses of radiation therapy. So I do push my patients to get radiation. There are some that refuse, and then I think chemotherapy would probably be better than nothing, but I have no data to back me up.
Thank you. So if you have any more questions, you can certainly meet with presenters and ask them questions.